So until now we have discussed about the micro-invasive cancer where the depth is going to be less than equal to 5 millimeter deep, right? So when the depth is less than 5 millimeter, which is micro-invasive, the treatment can be up to type 2 or type 3 hysterectomy. But right from stage 1B1, 1B2, where the cancer is going to be macro-invasive in nature, where the depth is going to be more than 5 millimeter. So right from here, the treatment of choice in elderly females has to be type 3 hysterectomy, that is radical hysterectomy, where you're going to remove the uterus, cervix and the surrounding ligaments, nerves, plexus and the tissues are going to be removed. Right, for stage 1B1, 1B2 and stage 2A1, you have to do radical hysterectomy, that is type 3 hysterectomy. Right? Okay. So in stage 2A1 also the parametrium is not involved. So just to give you a confirmation, in stage 2A1 also the parametrium is not getting involved. So right from which stage the parametrium is going to get involved? From stage 2B, the parametrium will get involved. So until stage 2A1, the parametrium is not getting involved. So now let's have a quick gist of whatever we have discussed until now. So stage 1A1 is all about micro-invasive cancer, that is stage 1A. Stage 1B is all about macro-invasive cancer. In 1A we have 1A1 and 1A2. So stage 1A1 without the lymph vascular space invasion, the treatment of choice in young female is going to be conization. In elderly female it is going to be type 1 simple hysterectomy. Stage 1A1 with lymph vascular space invasion, the treatment of choice in young females is radical trachelectomy. In elderly females it is going to be type 2 or modified radical hysterectomy. But stage 1A2 is concerned, starting from stage 1A1 with lymph vascular space invasion to stage 2A1, the treatment of choice in young female is always radical trachelectomy, because these are the early stages of cancer where the cancer is actually localized and it hasn't have any spread now. So all these stages, the treatment in young females has to be radical trachelectomy. Is that clear? Yes. So for stage 1A1 with lymph vascular space invasion, 1A2, 1B1, 1B2 and 2A1, the treatment is radical trachelectomy in young females. Whereas in elderly females, the treatment in 1A2 is going to be either type 2 or type 3 hysterectomy, but definitely starting from stage 1B1, 1B2 and 2A1, the surgery is going to be radical hysterectomy or type 3 hysterectomy in elderly females. Is that clear? Okay. So the parametrial involvement starts from stage 2B only. Parametrium is involved in stage 2B, and when does the pelvic side wall is getting involved? The pelvic side wall will get involved only in stage 3B, right? In stage 2B, parametrium will involved. In stage 3B, pelvic side wall will get involved. Clear? And the lymph nodes will start getting involved right from stage 3C. Clear? Yes, so this is all about the surgical options which are available in young females and elderly females. Clear? So with this we have dealt about the surgical management. Now we are going inside the radiotherapy. So as the radiotherapy is concerned, it is the treatment of choice for what? It is the treatment of choice for any later stage cancers like stage 3, stage 4, stage 2B, stage 1B3 and stage 2A2. Clear? Stage 3 is when the pelvic side wall is getting involved, the hydroureter, hydronephrosis, and the stage 3C where the lymph node is getting involved. Stage 4 is all about the metastasis. 2B is when the parametrium is getting involved. 1B3 and 2A2 are the size of the tumor is more than equal to 4 cm. So it is the treatment of choice for stage 3, 4, 2B, 1B3 and 2A2. Clear? Yes. Now in radiotherapy we have two types. One is brachytherapy and the other is teletherapy. One is brachytherapy and the other is teletherapy. So what do you mean by brachytherapy and what is teletherapy? Brachytherapy is an intracavitary therapy. Is an intracavitary therapy where you're going to keep a radiation source inside the person's body, right? You're going to select a point which is near to the site of the cancer, and you're going to insert a device, and that device is going to just expel out the radiation source. So the radiation source is actually in the one of the body cavity, so it is an intracavitary therapy, whereas teletherapy is an external beam radiation. The radiation source is going to come from the external source, so it is an external beam radiotherapy. Clear? Yes. So what is the isotope which is used in brachytherapy and teletherapy? The isotope which is used in the external beam radiotherapy or the teletherapy is cesium, whereas in brachytherapy it is iridium 192. Please remember, it is iridium 192. Right? So which is the first, brachytherapy or the teletherapy? You have to do the external beam radiotherapy first, which will shrink the size of the tumor, which has to be followed by the intracavitary therapy. So always the first thing which has to be done is the external beam radiotherapy. This external beam radiotherapy is going to shrink the size of the tumor, and once it's going to shrink the size of the tumor, now you keep a source of radiation inside the body cavity, which is the intracavitary therapy or brachytherapy. Clear? So it is an the radiation from the outer source. Brachytherapy, the radiation is from the intracavitary. It is going to be kept at point A. What is point A? Point A is about 2 cm above and lateral to the external os. Point A is 2 cm above and lateral to the external os. Right? Where is point A? Point A is situated about 2 cm above and lateral to the external os. So in point A, you are going to keep the source of radiation, and this source of radiation is going to expel the radiation, and it is going to result in the radiation therapy. Right? So initially it is teletherapy, which has to be followed by the brachytherapy, external beam radiotherapy, which will shrink the size of the tumor, which has to be followed by the intracavitary therapy. This will also help in destroying the tumor cells. Clear? Yes. And one important point is that this external beam radiotherapy, it can't be done in a single day. It has to be divided in fractions, and it will be administered about 50 gray. Radiation is always expressed in terms of gray. About 50 grays has to be administered in a period of about 5 weeks. So in a period of about 5 weeks, 50 grays of radiation will be administered. Clear? Okay. So this is all about the radiation. Now, what are the parts where the radiation is going to involve? So radiation is going to be mainly involving it is whole pelvic radiation, right? Whole pelvic radiation has to be given, and this whole pelvic radiation will definitely involve the lymphatic drainage of the cervix as well. As we all know, the paracervical, the parametrial, obturator, interiliac, externiliac, common iliac, and the para-aortic lymph nodes. So all these lymph nodes along with the whole pelvis will be included in the radiotherapy. Is that clear? Okay. So what are the side effects of radiotherapy? The side effect is that since it is whole pelvic radiation, the first side effect, the most important side effect is that it can lead to ovarian failure. Because please remember, ovaries are the most radiosensitive. Ovaries are most radiosensitive. So because of that, there could be ovarian failure followed by vaginal fibrosis. Because of radiation, there could be fibrosis, right? So let's say this is going to be the normal path. Because of this radiation, there is going to be many formation of fibrous strictures between the two walls, and because of this radiation, there could be fibrosis. So vaginal fibrosis and ovarian failure are the side effects of this radiation therapy. Clear? So this is all about the radiation. So radiotherapy is the treatment of choice for stage 1B3, 2A2, 2B, and stage 3 and 4. Clear? Yes. So now what is chemoradiation? The third is going to be chemoradiation. Chemoradiation is nothing but prior to the radiation you have to administer chemotherapy. So this chemotherapy will act as a radiosensitizer. So what are you going to do is that you have to administer chemotherapy to the patient. Chemotherapy is where you're going to administer cytotoxic drugs through intravenous route, and the cytotoxic drugs will actually shrink the size of the tumor as well as it will increase the sensitivity of the tumor to the upcoming radiation. So this chemotherapy is actually a radiosensitizer. It is going to sensitize the tumor cells to the upcoming radiation. So cisplatin is the agent of choice in cancer cervix. If not, cisplatin is not available, 5-fluorouracil can be used as cytotoxic agent. Right? So this chemotherapy is actually a radiosensitizer. And this chemotherapy is ideally done before the radiation, and this chemotherapy acts as a radiosensitizer. So following this chemotherapy, radiation therapy has to be done. Is that clear? Yes. So this is all about the chemoradiation. Now coming to the lymph nodes. So as we all know, lymphatic spread is the most common route of spread of cancer cervix. Right? As we all know, what are the lymphatic drainage of the cervix? These are the paracervical parametrial lymph nodes which drains inside the obturator, and from the obturator the lymph is going to drain inside the internal iliac, external iliac, common iliac, and then finally into the para-aortic lymph nodes. So the best investigation for assessing the lymph node involvement is when the lymph node size is less than 5 mm. The best is going to be PET-CT. Right? It is more sensitive. But if it is going to be more than 5 mm, then CT is the investigation of choice for assessing the lymph node involvement in a patient of cancer cervix. Right? Okay. So alternatively, instead of PET-CT and CT, you can also do the other investigations in detection of lymph node involvement in a patient of cancer cervix, and that is all about the sentinel lymph node biopsy. Sentinel lymph node is nothing but it is the first lymph node to get the lymphatic spread from the original site of origin of the tumor. So in order to find out what is the first lymph node which was actually got involved from the original site of cancer is through sentinel lymph node biopsy, where for the biopsy you are going to inject a radio tracer. A radioactive tracer is actually injected. This technetium, yes, it is injected, and the lymph nodes which are getting positive upon staining by this radioactive tracer is the sentinel lymph node of cancer cervix. So how is this procedure is actually done? So this procedure is done when the size of the tumor is less than 2 cm. So when the size of the tumor is less than 2 cm, and in all the early stages of cancer, sentinel lymph node biopsy is very useful, right? So in later stages of cancer, you don't have any option. If there is involvement of the lymph nodes where you detect it through either the PET-CT or the CT, you have to undergo lymphadenectomy where you're going to remove the lymph nodes. But in early stages of cancer, when the size of the tumor itself is less than 2 cm, you can go with the sentinel lymph node biopsy, where you're going to inject a radioactive tracer such as technetium, and you're going to observe whether the lymph nodes are coming positive or not. If the lymph node is getting stained with the dye, it is positive. If it is not getting stained with the dye, it is negative. Clear? Yes. So if the lymph nodes come to be positive on sentinel lymph node biopsy, what are you going to do? If it comes to be positive, then it signifies that it is the later stages of cancer, where the stage is going to be definitely 3C, because we all know only in stage 3C1 and 3C2 lymph node is getting involved. So if the lymph node comes to be positive, then definitely it is the later stages. So in later stages you have to do whole pelvic radiation. this also called as chemoradiation has to be done. Right? Clear. But if in case on sentinel lymph node biopsy, if the lymph node comes to be negative, the lymph node comes out to be negative. So now, since it is an early stages of disease, so because it is an early stage of disease, you're going to do the hysterectomy in that patient. Let's say, for example, you're going to do a hysterectomy. So you have done the hysterectomy and the lymph node dissection is also done because the lymph nodes are not grossly positive. The lymph nodes are not grossly positive, so for that reason you're going to do the lymph node dissection. But if the lymph nodes are positive, then definitely it signifies it is the later stages of the disease, such as the stage 3Z, where you have to do chemoradiation. But in earlier stages of disease, while the lymph nodes are not positive and it is actually negative, in that cases, along with the hysterectomy, you can do lymph node dissection. So when you do the lymph node dissection, you will subject the lymph nodes to the histopathological examination. If the histopathological examination comes out to be negative, it is well and good. But if it comes out to be positive, you have to follow up it with post-operative chemoradiation has to be given because the lymph nodes are positive on histopathological examination. It is very simple. See, sentinel lymph node biopsy is where you can detect the original lymph node which has actually get involved from the original site of cancer. That is the first lymph node get involved to get the extension from the original site of the cancer. And this sentinel lymph node biopsy is useful in earlier stages of the disease and when the size of the tumor is less than 2 cm. So when the size of the tumor is less than 2 cm and in earlier stages of the disease, you can go with this sentinel lymph node biopsy. If the lymph nodes are positive, you don't have any option because when the lymph nodes are positive, it means that it is actually stage 3Z, and in stage 3Z, the treatment is going to be chemoradiation. Right? The treatment is going to be chemoradiation. So you do the chemoradiation in that cases. But if the lymph nodes are going to be negative, then since the lymph nodes are negative, you can go with the hysterectomy since it is an early stage of cancer because the lymph nodes are not positive. So go with hysterectomy and lymph node dissection, and while you do the lymph node dissection, you will subject the lymph node to the histopathological examination, and in histopathological examination, if the lymph nodes are negative, it is well and good. If it is going to be positive, you have to follow up it with post-operative chemoradiation because the lymph nodes are positive on histopathological examination. Clear? Okay. So what about lymphadenectomy? Lymphadenectomy is nothing but removal of the lymph nodes. Removal of lymph nodes. What lymph nodes? Are you going to remove the lymph nodes of the whole body? No. You're going to remove the lymph nodes where the cervix drains into. So wherever the cervix drains into, those lymph nodes are getting removed, such as the paracervical, parametrial, obturator, internal iliac, external iliac, common iliac, para-aortic, and the rectal lymph nodes are removed. So it is ideally done in stage 1A1 with lymph vascular space invasion to stage 2A1. Is that clear? 1A1 to stage 2A1, 1A1, 2A1, 1A1 with lymph vascular space invasion to stage 2A1. Lymphadenectomy is done. It is not done in the later stages. Right? So in later stages, lymphadenectomy is not done. But in the earlier stages, the lymphadenectomy is done from stage 1A1 to stage 2A1. Is that clear? Yes. So this is all about the lymphadenectomy. Now, what is the actual side effect of doing this lymphadenectomy? So the side effect of doing this lymphadenectomy is it can cause lymphedema. So because of you are going to remove the lymphatic drainage, that is lymph nodes are getting removed, the lymphatic drainage gets hampered. So since the lymphatic drainage gets hampered, it is going to result in accumulation of the lymph. That is called as lymphedema. So lymphedema is the side effect of doing lymphadenectomy. So in earlier stages of cancer, starting from stage 1A1 to stage 2A1, lymphadenectomy can be done. But right from the stage 2A2, lymphadenectomy cannot be done because those are the later stages of the cancer where lymphadenectomy cannot be done, and you have to go with the chemoradiation because chemoradiation is the treatment of choice starting from stage 2A2. Clear? Yes. So starting from stage 1A1 to 2A1, you can do lymphadenectomy. The side effect is lymphedema. Clear? Yes. The one important note I have to tell you here is that the superficial inguinal lymph node is not getting involved in cancer cervix through the lymphatic invasion. Superficial inguinal lymph node is not getting involved in cancer cervix through lymphatic invasion because it is not linked with the lymphatic drainage of the cervix. If superficial inguinal lymph node comes out to be positive in cancer cervix, it means that distant metastasis is present. Distant metastasis stage 4B. So definitely superficial inguinal lymph node removal is not done in any case of cancer cervix. If it comes out to be positive, then it signifies that distant metastasis has occurred, which is actually stage 4B, where palliative care is the only treatment of option. Palliative care is the treatment of choice, where you do chemoradiation. Clear? So the treatment which we have discussed until now is all about the stage 2A1. Right? We discussed about stage 1A1 without lymphocyte space invasion, 1A1 with lymphocyte space invasion, 1A2, 1B1, 1B2 and stage 2A1. So starting from stage 2A2 till stage 4, the treatment is only chemoradiation. The treatment is only chemoradiation. You give chemotherapy, it acts as a radiosensitizer, followed by you give the radiotherapy. That is the teletherapy followed by the intracavitary brachytherapy. For stage 4, it is always palliative care. Only palliative care is given in stage 4 because in stage 4 we have the metastasis, both the regional as well as the distant metastasis. Clear? Right from stage 2A2 to stage 4, chemoradiation is the treatment. For stage 4A, 4B, only palliative care, that is the chemoradiation is given. So starting from stage 1A1 to stage 2A1, the surgical options have been discussed here. Clear? So I hope everything is clear now as of the cancer cervix is concerned. If you have any doubts, or if you want to repeat the topic for you, or if you want me to make this topic even more simpler for you, please write to us in the Mackler handle. We will come with an even better version of cancer cervix, right? So when we do the revision classes in the future, this will be even more shortened and we will just go it as a gist. Clear? Yes, so let's meet in the next another interesting module. I'll be discussing about the further